Hello, my name is Abdu, and I'm going to be giving a lecture today on cerebral palsy and head control. So, before we talk about head control, we first have to talk about what is cerebral palsy. So, CP is a group of disorders that affect a person's ability to move and maintain balance and posture. CP is the most common motor disability in childhood. It is a group of permanent disorders affecting the development of movement and causing a limitation of activity. The degree and type of motor impairment and functional capabilities vary depending on the etiology of the patient. So, what is actually the cause of cerebral palsy? The main cause of cerebral palsy is brain injury caused by a lack of oxygen to the brain before, during, or shortly after childbirth. Brain damage caused by a lack of oxygen, which is hypoxia, can result in an array of symptoms such as issues with fine motor skills, movement, coordination, and muscle tone, and developmental delays. So, what does cerebral palsy patients experience actually as people? So, all people with cerebral palsy have problems with movements and posture, and some also have some level of intellectual disability and abnormal physical sensations or perceptions, as well as other medical disorders. So, people with CP also may have impaired vision or hearing, and language and speech problems. So, how do we detect cerebral palsy? You can see it in the developmental milestones, the developmental delays, especially of the child. He is slow to reach milestones such as rolling over, sitting, crawling, and walking. Also, history taking of the prenatal, perinatal, and postnatal history. You could know through the complications during those periods if they have cerebral palsy or not. Also, abnormal muscle tone of the child. Body parts are usually floppy or too stiff, and there is an abnormal posture. So, infants younger than 6 months of age cannot hold up their head when picked up from lying on their back, may feel stiff or floppy. When picked up, their legs get stiff. When held, they may overextend their back and neck, constantly acting as if they are pushing away from you. Infants older than 6 months of age cannot roll over, cannot bring their hand to their mouth, have a hard time bringing their hands together, and they tend to reach out with only one hand while holding the other in a fist. Infants older than 10 months of age, they tend to crawl by pushing one hand and leg while dragging the opposite hand and leg, especially if it's hemiplegia, so it's one sided cerebral palsy. They tend to also scoot around on their buttocks or hop on their knees, but they do not crawl on all fours. They cannot stand also, even when holding on to support. So, in cerebral palsy, as we now know, there is a delay in motor development. A history of developmental regression is not constant with cerebral palsy. So, if they achieve something and then it regresses, that means it's not cerebral palsy. Family history is also important to actually be taken as well. Multiple family members with similar delayed developmental or neurological disorders as the patient should prompt consideration in history taking for diagnosis of cerebral palsy. A physical exam should be done also to identify the cerebral palsy type, such as spastic diplegic. The patient has spasticity and motor difficulties affecting the legs more than the arms. There is also another type, which is spastic hemiplegic. The patient has spasticity and motor difficulties affecting one side of the body. The arms are often involved more than the legs. And spastic quadriplegic, the patient has spasticity and motor difficulties affecting all four extremities, often greater involvement of the upper extremities than the legs. Also, there is dyskinetic or hyperkinetic chorioathetoid. The patient has excessive involuntary movements. It's characterized as combined of like combination of rapid and dance-like contractions of muscles and slow movements. There is also dystonic. The patient has involuntary sustained muscle contraction, causing twisting and repetitive movement. This is actually a diagram that can help you identify the different cerebral palsy types. So, another important aspect actually is identifying the prognosis of a CP patient. So, most children with cerebral palsy will survive into adulthood. Severely affected patients have a reduced life expectancy, but the most common cause of early death is respiratory disease, usually aspiration pneumonia. The prognosis of motor abilities depends on the cerebral palsy subtype, so the rate of motor development, ascertainment of developmental reflexes, and cognitive abilities. Children who walk independently typically achieve this milestone by 3 years of age. Those who walk with support may take up to age 9 years to reach this milestone. A child that is not walking by age 9 years is unlikely to walk even with support. So, children with hemiplegic, chorioathetoid, and ataxic cerebral palsy are likely to achieve walking. A good prognosticating factor for independent walking are sitting by age 24 months and crawling by 30 months. A poor prognosticating factor for walking include not having achieved head balance by 20 months. Primitive reflexes are usually retained, and there is no postural reflexes by age 24 months. And not being able to crawl by age of 5. That's really a big factor. So, as previously mentioned, head control is very important to achieve in a CP patient before the age of 20 months old to have a better prognosis of walking later on in life. So, we will be discussing some techniques on how to develop head control in patients with CP. So, if we have a hypothetical case of CP spastic quadriplegic with poor head control, some of the techniques that may be used for the patient is the most important concepts of positioning and key points of control. So, as we can see in the example here, you can see in image 1 and image 2, the therapist has the patient place on her lap with the hips in between their legs to prevent the extensor tone from manifesting when the patient tries to control their head position. The therapist can also place the patient in cross-legged position to prevent extensor thrust from manifesting. Further, while focusing on head control exercises, basically with her other arm, the therapist places her arm behind the neck to help support the head if the patient has too much difficulty in bringing their head back to neutral. So, positioning is really important, and knowing the key points of control to how to actually handle the patient is very important. Next is another technique is if the patient is an infant that is really young that you cannot have them sit upright yet. You may facilitate head control by doing a technique called pull to sit. You can facilitate head flexion by tapping on the neck flexors as if you're tickling them to bring their head upright. The therapist grabs the baby by the shoulders and necessarily adjusts the incline of the patient to utilize gravity as the resistance in developing the muscles of head control. So you could actually bring up your knees up to increase the incline, or decrease the incline to increase the resistance of the gravity on the neck flexors. So in conclusion, there are so many concepts actually and ways to develop head control in CP patients. You just need to get creative and may try to understand the different concepts and theories behind them for you to develop your own personal method. So thank you for listening and have a wonderful day.